let us come to the next topic. Percutaneous valve interventions, what's happening at the frontier of science, by Dr. Sengottuvelu, and to chair the session, we have Dr. Rakesh Yadav and Dr. S. Ramakrishnan.
Very well, yes, sir. And I think Dr. Sengottuvelu needs no introduction. He's a master of his own thing,
craft.
And let us learn from the master's voice.
Rama is there?
Yes, sir, I'm here, sir.
Okay, fine.
Let us have the lecture. We can have the discussion later.
Okay.
Can I start?
Yeah, please.
Good evening, all of you, and thank you, Dr. Santana Guha, for the kind invitation, and thank you, Dr. Rakesh Yadav, for a very nice introduction. Thank you so much, and let me now start my talk and share my screen. Can you see my slides now?
Yeah.
Okay. So percutaneous valve interventions, so what's happening at the frontier of science? So we know that the field of interventional cardiology is one of the very rapidly evolving area with very vibrant today's medicine. Although surgery for diseased heart valves have been established as ultimate cure, now with the new advances, we can manage these patients with the transcatheter therapies. So it started quite early, as in 2000. The first pulmonary valve replacement was done in man, first in man, and as early as 2000. And later on, following the pulmonary valve, a lot of animal studies, and then first in human study, first in man, TAVA was done by Alan Kripia, as you all know, in 2002. And then later, in 2009, was the first transcatheter mitral valve replacement for a valve-in-valve procedure, which was done through transapical approach. And then they started doing TMVR for mitral annular calcification. And today, 2014, and started, now we have several new devices which are dedicated for treating native mitral regurgitation. So if you look at first let me start with TAVI and then move to other valves. So if you look at the aortic valve, the TAVR evidence has been overwhelming in about the last decade. And it started with the partner trial, which again initially wanted to check whether the surgery is equal to surgery, and then followed by in high-risk patients, it was shown to be non-inferior or even superior to surgery. That is partner 1A trial with the Edwards sapien valve and the core valve study for the core valve from Medtronic. And then later on, they went for studying intermediate risk patients. Again, it was shown non-inferiority to compare to surgical aortic valve replacement. But recently, we also have shown the partner 3 trial. It has been shown for low risk patients as well. The results of transcatheter aortic valve replacement is again shown to be non-inferior to surgical aortic valve replacement. So with this rapid advances in the evidence base has led to tremendous growth of TAVI throughout the world. So today, TAVI is also having a lot of new design improvements in the valve. The delivery system has become smaller, and the effect of recapturability, the valve is not positioned well, can be corrected, and they have all improved the safety profile. The operators' technical knowledge, experience all grown, and the lower rates of stroke and also a reduced paravalvular leak is observed. Then also reducing the peripheral complications because of these smaller devices. In India, one of the biggest advantages we have indigenous valve, and that has led to the growth of TAVI in India. And my valve is a technology, again, done first in man study was done in India and has shown to be good results, and now it's available in Europe. So let me go a little more case-based. See, once the TAVI has grown to such a great extent that today we are dealing with a lot of complex cases. Like for this example, we have a bicuspid valve. Again, traditionally, tricuspid valve are the ones which are treated with the TAVI, but today with the expanding indications, and today this is an example of a bicuspid valve. where you have extensive calcium and calcium extending to left ventricular outflow tract. The bicuspid valve was very challenging in the sense we could not cross the aortic valve. And in this case, despite changing different types of catheter, using Amplats or Amplats right or Judkins, we were not able to cross. And finally, about 1 hour later, we decided that we go antegrade approach. We did a septal puncture, and in a minute, we were able to cross the aortic valve through antegradely. And then the job was we had to snare the wire through the mitral valve, aortic valve, snare the wire. And once we had the wire in the LV, we just have to put a pigtail and then put a balloon. And once we were there, we were able to do the balloon aortoplasty and followed by TAVI. So this was again a Merrill my valve, which was quite challenging to do. So now let me talk about the other valves beyond aortic. What are the valves beyond aortic? Let me first start at the pulmonary valve. In Indian perspective, about 38 valves have been implanted on a compassionate basis, both Melody, Venus B, and also in the as a my valve, which is being done in the pulmonary position. And let me just show you one of our cases again with pulmonary valve. This is a 26-year-old lady who had a tetralogy of Fallot, operated 10 years, and developed obstruction to the pulmonary valve at the age of 16. And they had surgically replaced the valve. She developed infective endocarditis, and then the valve has to be removed at 17 years of age, and infected valve was removed. And she had come with the pulmonary regurgitation. She wanted to get married, so we wanted to thought of doing a percutaneous approach. So since she had a conduit with a stent earlier, it was a little more easier for us to do a transcatheter valve implantation. This is again the same my valve, which is placed again through the venous system, and the valve is placed in the pulmonary position, and we implanted. So we have series of cases of pulmonary valve, and we have shown good results using also my valve in pulmonary position. So this is the final result. As you can see, there is not much of pulmonary regurgitation. This lady is now doing very well, more than 6 months now. She actually is going to get married, and so that was the main reason we did this procedure. And the PR is now eliminated for this lady. So tricuspid valve, the number of a series of available options for tricuspid valve, but the one easiest way to do is to valve and valve tricuspid valve. Our experience, we have done valve and valve tricuspid valve for this 28-year-old lady, again who had a surgical replacement, and following that, she had at age of 19 years, she had a BioCorp 31 millimeter valve, surgical bioprosthetic valve, and that was a failed bioprosthetic valve for which we did again a transcatheter tricuspid valve. So doing such procedures in a valve and valve is much more easier because it helps to anchor the transcatheter valve when we already have a valve in position. So we were able to get a good result, and this is following. We wanted to flare it at the right ventricular side, so the valve doesn't get embolized. And as you can see, there's a flared portion at the right ventricular side, and this patient did very well. So moving to mitral valve. So mitral valve is more challenging, and since the incidence of mitral regurgitation and the patients who have mitral regurgitation much more than aortic stenosis, the options of transcatheter valve therapy has been being explored for several years, and again, depending on the etiology, several options are available for patients. The valve repair, the transcatheter valve repair, is again being considered in a big way, like using devices such as mitral clip or Pascal devices for patients who have degenerative mitral regurgitation or functional mitral regurgitation. For patients for transcatheter mitral valve replacement, again it depends upon the overlying condition, and whether the patient has already a failed mitral valve bioprosthesis, or whether a failed surgical ring, or whether there is a mitral annular calcium. So in all the three situations, there is something to hold the valve in place. So mitral valve is more complex in the sense it is a saddle-shaped valve and it's a mitral valve is actually a valve apparatus. Unlike an aortic valve, has the leaflets, the chorda tendineae, the papillary muscle. So the mitral valve as such is more difficult to replace the valve. So having an anchor already, like in valve and valve or previous valve or a surgical valve, makes it easier for the valve to hold. But the challenge has always been doing mitral valve replacement in native mitral valve. So several areas have been explored, and as you can see in the slide, people have tried to do a kind of H2H repair, direct mitral annuloplasty, again through the coronary sinus, you can do indirect annuloplasty, and the other thing is a mitra clip, which is again it's H2H repair, which is again one of the most common therapies currently being used. And finally, the percutaneous mitral valve replacement, which I will talk about a little more in detail. So, if you look at the mitral regurgitation, as you know, the mitral clip is basically a device which converts a single orifice mitral valve into a two orifice. So, we place the clip by doing a septal puncture and then placing the clip in the right position and by making sure the clip is perpendicular to the plane of the annulus. And as you can see, the mitral valve, which is converted to a double orifice after placing the clip. So once you place the clip, the mitral regurgitation is eliminated completely, and you can see the double orifice now. So again, the mitral stenosis is a challenge, so it has to be carefully selected. And patients who already have a narrow mitral valve orifice, which is narrow, or depending on the plain leaflets, the number of criteria, which is anatomically very important to select the right patient for mitral clip. So mitral clip device, again, though it looks very complex, as you start doing, it is not much of a difficulty. As you can see, that there is a clip which is mounted on a stabilizer. There's a guiding catheter, and you have the clip delivery system, and through which the clip is delivered and deployed in the mitral valve. Similarly, there is one more device called Pascal device, which is by Edwards, which is also now CE approved. Just briefly, our experience: we have done a few cases of mitral clip. This is a 79-year-old man with symptomatic severe mitral regurgitation, and again we did a. Again, this procedure is completely guided by transesophageal echo, and about 80% is guided by TE, and about 10-20% by fluoroscopy. So it's very, very important to go to the catheter completely guided by TE. And this is a video of showing how the clip is being positioned and deployed, and the mitral valve MR being completely eliminated. And this is a echocardiogram after the placement of the clip. So, moving to transcatheter mitral valve replacement, as I told you, the substrate, the problem of native mitral valve has also always been challenging, but more commonly it has been done for valve and ring, and mitral annular calcification, because these three substrates have a anchoring in place. So putting a new transcatheter valve is really possible, because these existing structures help to anchor the new transcatheter valve. So if you look at the data, what we have, this is one of the registries in the US, and what they have shown is the hospital mortality is the lowest in patients with valve and valve, followed by valve and ring, and followed by MAC. So clearly, the best outcome was seen in patients who have valve and valve. Similarly, there is a vivid registry. This is also another large registry of 1,079 patients, which also showed the survival is more for valve and valve procedures compared to MAC or compared to valve and ring procedures. So, a number of dedicated TMVR devices are in the market today, and the cardiac device from Edwards. The other important device is from if you look at this device, Fortis, and this is the device from Abbott, Tendyne device. this device has recently received a CE approval after we showed the 2-year data were very promising. And also Edwards is planning a Sapien M3 valve. And Intrepid by Medtronic is again one of the valves being studied and recently presented the data in the PCRUP course. So this is data from the Tendine valve, which was again presented in the PCRE course, where they showed 2-year results of the Tendine valve. This is a procedure is done by, initially they were using transapical approach, and now they were also started using a transseptal approach. So this technical success was almost 96%, and the procedural mortality was 0, and the disabling stroke was 5%, and the nuanced need for pacemaker was 8%. So basically, the result was appearing quite good with the 96% success. And following that, they are going for a large trial and will soon get FDA approved. So this is one of the very promising therapies for natal mitral valve. The other system, Medtronic system of Intrepid, again, this is a system which was done with transapical approach. And now recently they have come out with a transfemoral system, and they have a pilot study which is again shown very promising results. All these valves, mitral native valves, have 2 valves in place, even both the Tendine valve as well as the Intrepid system. One is a standard valve, which is inside what you see is an outer ring. There is a valve inside, and that actually varies by size. So depending on the size, we choose that. And the outer ring is kind of a saddle shape, so it fits into the orifice of the mitral valve, mitral annulus. So let me show some of our experiences with the valve-in-valve procedures. This is again a patient who had a previous mitral surgical valve replacement with BioCor valve, which was failed. And we have to look into CT as well as now we have valve-in-valve app, which gives an idea of what valve to put in and what size to choose. And the radio opacity of the valve is again very important, because in this BioCor valve is very less radio opaque, and so positioning it is going to be somewhat challenging. So it's important to know about the details of the previous surgical valve, its fluoroscopic appearance, and the valve size what the surgeons have used. So once you have these data, the CT will help us. What we do is virtual valve implantation. We can place a valve in the CT. For example, here we choose a 26 millimeter valve, and by doing that, we can measure whether the new valve can cause LVOT obstruction. One of the major challenges for transcatheter mitral valve is once we put in a new valve, it can cause left ventricular obstruction, LVOT, left ventricular outflow tract obstruction. So we always calculate the new LVOT area. So the CT can help us. So once we put a valve, a virtual valve, we can measure the new LVOT area and then accordingly decide. So whether generally if you have a new LVOT which is about 250 millimeters square, then I think it's more safe to implant the valve without causing LVOT obstruction. So this is again Achilles catheter. We did a septal puncture. We cross through the septum. We cross the mitral valve. If we're doing a septal dilatation with a 12 millimeter balloon, a prolonged septal dilatation, and then we take in a my valve, and once we take it in, we implant the valve very slowly. This actually we don't need rapid pacing unlike aortic valve, and this is the final result. This patient did extremely well. So this is the echocardiogram before procedure. You can see a tight stenosis, and this is after the procedure, where you can see a mitral valve which is nicely open, no mitral regurgitation. There are no significant gradient and no paravalvular leak. So to conclude, to start with aortic valve, TAVI has today become a standard established therapy for treatment of aortic stenosis. A decade after commencement of the TAVR trials, Now, the procedural safety is increased to a great extent thanks to the newer technologies and more experience. And today, lesser invasive approaches called less invasive TAVI are preferred with conscious sedation and early discharge. Less concern about long-term durability, and a lot of importance is given to heart team approach and choose the best therapy for that particular patient depending on the patient's anatomy and the surgeons and the interventional cardiologist decision. And device evolution has contributed to improve outcomes. So mitral interventions, transcatheter mitral valve and mitral clip is available and approved in India. It is indicated in high surgical risk patients and can be done with both degenerative and functional mitral regurgitation. For transcatheter mitral valve replacement, it has been well established in degenerated bioprosthetic valves or annuloplasty rings, for which regular transcatheter heart valve designed for aortic valve can be implanted with very good success. In native valve mitral regurgitation, several dedicated systems have been developed, and of interest, the Tendyne device from Abbott Vascular has received CE approval recently for native mitral regurgitation. And interestingly, the 2020 ACC expert update has included percutaneous mitral valve therapy as a treatment option for mitral valve disease. And our experience also has shown very good results with mitral clip and valve. One thing is the mitral clip, we have only reduces the MR from grade 4 to grade 2 or grade 3 to grade 1, but it doesn't eliminate MR. And it's only done in patients who cannot undergo surgery or have extremely high risk for surgery. So there are other interesting developments happening in the field. So, like for example, new tissue engineered valves are being pursued, and also use of biodegradable scaffolds configured to the shape of the native valve and seeded with the potentially derived stem cells. So the idea is the scaffold will disappear and the valve will proliferate. So that is many new thoughts are being considered and developed. And but today, definitely interventional cardiology in the structural heart fund has progressed in several areas, and it's become a reality to treat these difficult patients, even patients who have another option when surgery is considered as high risk. Thank you for your patience.
Thank you for such a wonderful talk. You have taken through the journey of all the valve therapies, how they evolved, and your experience has been nicely shared. So I have a few comments like you showed bicuspid aortic valve. So is the success rate has a similar rate of success achieved like in other etiology of aortic stenosis?
Thank you. So as you said, the bicuspid valves are more challenging anatomy because these valves are more calcified. They also are associated with aortopathy. So the technical challenges are there, and the long-term outcome again has not been shown to be as good as in patients with a tricuspid valve. So, but today in India we are seeing, or at least in our experience, patients who come for TAVI, nearly 50% of patients are bicuspid aortic valves. Maybe because we are seeing more younger patients.
So have you encountered all these thrombosis the valves like?
Yeah. So I have not encountered any valve thrombus, but it has been established a subleaflet thrombus, particularly with balloon expandable valves, and also frank valve thrombus has been shown, and it is diagnosed by echo when the gradients go up, but the CT will clearly show the presence of thrombus, and whereas subclinical thrombus cannot be seen by echo, the gradients will not go up, and CT will clearly show a subclinical thrombus. So it has to be treated like how we treat a surgical thrombus struck valve with like thrombolysis, depending on the presentation. Whether the gradient is very high, then it has to be treated.
So what has been your anticoagulation and antiplatelet protocol and CT follow-up protocols?
So generally, we don't do a CT for follow-up unless the patients are on study or under follow-up. We don't do a CT. For anticoagulation, many of these patients are having some condition like pre-existing atrial fibrillation or patients with a previous surgical another mechanical prosthesis where anticoagulation is necessary. Otherwise, patients with the transcatheter aortic valve replacement do not need anticoagulation as a routine. We give only dual antiplatelet therapy. For balloon expandable valve, it is recommended for 6 months of BAPT followed by single agent. For self-expanding valves, it is recommended 3 months BAPT followed by single antiplatelet drug. So that is a general recommendation. For mitral position, generally the risk of thrombus is very high, particularly for a valve-in-valve procedure. We tend to give anticoagulation for a short period of time. Even though this is a tissue valve, we give it for about 6 months, like how we give for a surgical after a surgical tissue valve. We sometimes give a short duration anticoagulation. Similarly, we give for a short time.
Rakesh, any comments?
Only one comment. How long you expect this valve will last in a patient?
Okay.
Because this is a common question which a patient asks. Is there the newer valves which has surgical valves last 25 years? How long these valve will last? So what is your comment?
We only can go with the evidence and data. So at the moment we have data up to 10-year data, which is the durability data is showing a lot of promise. But again, we don't have strong data similar to surgical valves, which will only come over a period of time because procedures are relatively new. So, so I would say that probably you can always extrapolate from the surgical data and tell these patients these procedures generally last 10 to 15 years. When I talk to my patient, I always, the same questions are asked, and I always tell them it's around 5 to 15 years. It's like the surgical valve sometimes fail early. Similarly, we have to tell majority of them 10 to 15 years is what is the average. I generally tell my patients.
But some of the loss of valve area is actually lesser with TAVI as compared to SAVR. Some of the data is suggesting. The loss to valve area, the valve area loss is actually lesser with TAVI as compared to SAVR.
Yeah, that's true, absolutely true. The only thing is we don't have a longer term follow-up. Hopefully we will have over time. But as you said, it is very promising.
So one more comment, like, do you think any of these procedures will come for our own problems like rheumatic heart disease? Any of these valve therapy will ever come?
Yeah. See, the problem with rheumatic etiology is it doesn't have, there is no calcium. So when you have a valve without calcium, again the problem of anchoring. We cannot anchor the valve, the transcatheter valve. So that is the challenge of calcium. But again, we have done, for example, we had done a few cases of rheumatic because patient had multiple comorbid and no other options available. So what we did was we oversized the valve and used a balloon expandable valve, oversized it, and the valve fixed. But again, the risks are higher. So that is one of the big challenges in use in rheumatic etiology. But again, mitral valve still in India, we have not done, nobody has done any case for native mitral valve. Hopefully the dedicated devices when they come may hold promise for treating mitral regurgitation, even rheumatic etiology.
Any other questions, comments by anybody? Wonderful talk. Thanks. Thank you very much.
Welcome.
Wonderful talk. You took us.
Thank you. It's a privilege to be in your meeting, and thank you very much.